Welcome to MedSynapse Medical Podcast. I'm your host, Dr. Nigar. Today, we're thrilled to have Dr. Navdeep Singh Panu as our guest. Dr. Navdeep is a highly regarded consultant obstetrician, gynecologist, and fertility specialist at TMC Fertility Center in Puchong, Malaysia, where he currently serves as a medical director. With a wealth of experience and expertise in his field, Dr. Navdeep has earned a strong reputation for his dedication to providing exceptional care to his patients. Dr. Navdeep obtained his specialist training at the University of Malaya, where he achieved his master's degree in obstetrics and gynecology. He is also a member of the Royal College of Obstetricians and Gynecologists. Additionally, Dr. Navdeep trained in laparoscopic surgery in India, acquiring a fellowship and diploma in minimal access surgery to further enhance his surgical skills. Additionally, Dr. Navdeep attended a course on assisted reproductive techniques at the National University of Singapore. With his broad knowledge and commitment to staying at the forefront of advancements in reproductive medicine, Dr. Navdeep has become a trusted specialist in obstetrics, gynecology, and fertility. Welcome, Dr. Navdeep.
Thank you very much, Dr. Nidra, for a nice introduction and quite elaborate introduction. I appreciate it, and thank you very much for inviting me to this talk today.
Thank you so much for joining us today. Now, today's discussion will focus on the importance of progesterone in vitro fertilization, supporting the luteal phase. Before we begin, I would like to ask one question. Dr. Navdeep, considering your experience and expertise, what advice would you give to aspiring doctors who are passionate about pursuing a career in obstetrics and gynecology?
Well, my advice to them would be obstetrics and gynecology is a very demanding field. There's always an ups and always a downs, always a good news, and sometimes you have bad news and bad outcomes. But nevertheless, those bad outcomes shouldn't discourage you, and the good outcomes, the happy moments, should encourage you to continue with your passion in the field.
Wow. Thank you so much for your great advice for the medical students. Now, let's start with our podcast. The first question. Can you explain the importance of luteal phase support in vitro fertilization and why progesterone is commonly used for this purpose?
In IVF, the luteal phase support, which is done after the egg retrieval or once we start progesterone, it's a very important phase because that part will determine whether the pregnancy is successful or not. So progesterone is a very, very important aspect because with it, that will determine the window of implantation. Progesterone will also make the womb lining more favorable for pregnancy. When we add progesterones after the egg retrieval or even for frozen embryo transfers for 5 days, we add it, that will increase our pregnancy rates, will reduce the contractility of the womb lining, and hence the chances for a successful pregnancy is better. And we generally continue these progesterones till about 8 to 12 weeks. Sometimes most of the doctors go on to 10 to 12 weeks. So it's a very integral part of the IVF treatment that we give to patients.
Thank you, doctor, for explaining about the importance of luteal phase support using progesterone. Now, moving to the next question, what are the different forms of progesterone that can be used for luteal phase support, and what are the pros and cons of each?
Well, there are many types of preparations that we've been having now. Number one, which is the most common one used, is the vaginal progesterone. Well, those progesterones, they directly go to the cervix, hence they get absorbed directly into the womb. So the amount of progesterones inside the womb lining will be much more, hence it will be more efficacious. And it avoids the first pass by all the metabolisms in the liver and throughout the body. So it's one of the most commonly used and the best type of progesterones. The second one will be the injectables. There are two types of injectables. One is the deep intramuscular oil-based type of injectables. The good thing about it is that the amount of levels in the body will be high, but the negative point is that it's painful, and sometimes you have to give it for a few times during the preparation of the womb lining and after the embryo transfer. The other type is the aqueous type, which is more fluid based, more water based, and those are the newer types which are a bit more acceptable to patients because they are a bit less, they are less painful. Nevertheless, a lot of studies have shown that the injectable ones also improve the overall pregnancy outcome. In my practice, I generally prefer to use the injectables along with the vaginal type. The another type would be the oral preparations. Those are like the micronized natural progesterones or even the dihydrogesterones. The problem with that is that it's the side effects will be there, the nausea, the vomiting, the GI side effects. So, and also certain studies have shown that it's not as efficacious as the other type. There was a latest paper which was presented, which was published, where they used the dihydrogesterone, and they claim that the findings say that it's as good as the vaginal type of progesterone. So lately, a lot of doctors have moved towards the oral type because the benefit is easy, patients can easily take it, so you can achieve better compliance with that kind of preparation, which is the oral type. But most of the time, lots of doctors generally use a mixed type protocol where they give the vaginal progesterone along with the injectables. And nowadays, as I mentioned, the oral type too. So there are three main types of progesterones that we generally use.
Thank you, doctor, for giving us a thorough rundown of different forms of progesterone used to support the luteal phase. I believe your explanation helped us understand the advantages and disadvantages of each option. Now, moving to the next question, how do you determine the optimal dose and duration of progesterone supplementation for patients undergoing in vitro fertilization?
Well, the optimal dose currently, pharmaceutical companies have come up with the certain type of preparations, and those are basically standard preparations where we administer to patients according to their certain milligrams that they have made. So we doctors generally follow that, like one or two tablets 2 or 3 times a day, and the duration of to give the progesterone all depends on personal preference. Some doctors, they continue the progesterones till 8 to 10 weeks. Some even go up to 12 weeks in the pregnancy. Basically, the idea behind this is this: in an IVF pregnancy, there is a luteal phase deficiency or defect. During an IVF pregnancy, the corpus luteum is not producing sufficient amount of progesterone. Hence, they cannot maintain the endometrial lining. Hence, that's the reason why we give this progesterone, to maintain the womb lining and to make the womb lining more favorable for pregnancy. Now, the reason why we stop around 10 to 12 weeks is because by that time, the placenta would start to function. After 12 weeks, the placenta will start to function. So during that interim 10 to about 14, 12 weeks, that's when the placenta is already there, and hence you do not need to give any more progesterones to the patient. So basically, that's when we stop. Some doctors stop the progesterone when the heartbeat is present. But in my practice, I generally stop it at about 12 weeks in the pregnancy. And the amount of progesterone also varies between patient to patient, which is if a patient is obese or patient had history of recurrent miscarriages, then I would be more inclined to continue the progesterone till slightly at the later date, for example, even up to 14 or 16 weeks for that matter.
It's clear that tailoring the progesterone treatment to each patient's unique characteristics and keeping close eye on the progress is crucial. Like, it can be unique for each type of patient, right?
Yes, you're right. That's the reason why we prefer to individualize the treatment for all the patients. Because even some patients who have like certain issues like vaginismus, they are unable to insert the vaginal pessary, so we have to give them the oral tablets and even injectables to help in the luteal phase support.
Now, moving on to the next question. Are there specific patient factors or clinical scenarios that influence your decision regarding progesterone dosage or duration?
Yes, as I mentioned, if the patient were to have recurrent miscarriages um, or recurrent implantation failures, then I'll be more inclined to continue the progesterone till a later date, like for example till the 14th to even 16 weeks. And in certain patients that to have recurrent miscarriages, we will also add on other type of medication like aspirin or even low molecular weight heparin along with that those progesterones too, with the aim of trying our best to improve their pregnancy rates and reduce the miscarriage rates.
Also, I believe considering individual patient history and medical conditions affect the choice, right?
Yes, of course. If a patient were to have like vaginismus or they're unable to insert anything through the vaginal route, then we'll give them other forms of progesterones, oral or even injectables. And in patients who are very afraid of injections, and then they'll be more inclined to avoid the injectables for them. Another type of issue would be if the patient is allergic to peanuts, because the injectables, the hydroxyprogesterone caparate, is oil based and it's basically a peanut oil based. So hence it's also very important for you to ask the question whether are they allergic to any type of medication or food, for example peanuts. If they are, then you have to stay away from the hydroxyprogesterone acetate injection.
Wow. I didn't know this. Thank you so much for giving a detailed answer on this question, doctor. Now, moving on to the next question. Are there any alternative or adjunctive treatments to progesterone that you consider for luteal phase support in specific cases?
Yes, there's a certain type of medication which will reduce the contractility of the womb lining on the structile. That's what we can give to patients where we've been having recurrent implantation failures, or we notice there's some contractions in the womb lining and in the endometrium. And secondly, we also can give things like nifedipine. Nifedipine is a calcium channel blocker. It's a type of antihypertensives, which some of us tend to give also to reduce the contractions in the womb lining. The other things would be if we suspect there is certain immune problems, immune reasons why the patient is unable to conceive, then certain doctors do give low dose prednisolone to patients too during the luteal phase, generally between 5 to 10 milligram once or twice per day for between a week to about 2 weeks after the embryo transfer. The other things would be certain centers tend to give things like the intralipid. Intralipid is type of parenteral nutrition which we give. Intralipid is supposed to reduce the immune response against the embryo. Hence, they claim that it can increase the pregnancy rates. In my practice, I generally do give things like prednisolone. I do give things like the low molecular weight heparin, even aspirin to my patients. As for the other modalities, I don't really use them in my practice, but there are a lot of people who do it. But the evidence base behind it, for example, for intralipid, is not very strong.
That's very interesting, doctor. It's good to know that we have options beyond progesterone when it comes to luteal phase support. Now, the next question is, what are the potential side effects or risks associated with progesterone supplementation during the luteal phase, and how do you manage them?
the commonest the commonest side effect of using progesterone, number one is if bloated sensation, feeling of nausea, vomiting, fluid retention, and certain patients feel that they feel sleepy, tired, drowsy, dizzy. So constipation is another type. So all these symptoms are quite commonly seen when your progesterone levels are high. Some women tend to get it during the ovulation time, or even just before the menses, like the premenstrual symptoms. So basically, we're trying to treat them symptomatically. They have any constipation, we give them some laxatives, or nausea and vomiting, and give them some antiemetics, or any gastritis medication. That's about it. And the problem is we can't do without the progesterone. So we tell the patient we'll try our best to minimize the exposure, the duration and the dose for them according to their conditions. And but generally most of the patients thankfully tend to be quite okay with that medication and with a mild side effect. The other side, that I would say the worst side effect would be from the injectable progesterone, where we give the deep intramuscular hydroxyprogesterone caproate. That you can tend to have a sterile abscess in the buttocks because since it's deep intramuscular. So you have to ensure that when you give it, you have to use a sterile swab. Make sure we do not cause any infections, and if in case the patient has a sterile abscess, then you have to treat it accordingly and maybe avoid the subsequent doses. And the other one would be, since it's deep intramuscular, it's painful, so you might have to alternate the site of injections at every time you give it. And so those are basically the commonest side effect. And if the patient were to have very bad gastrointestinal side effect, for example, gastritis, nausea, vomiting, and then you might want to avoid the oral preparation and just stick to the vaginal route for them.
Dr. Navdeep, in your experience, what are some common challenges or misconceptions among doctors when prescribing progesterone for luteal phase support?
Well, the common misconceptions would be that you have to give a very, very high dose, or you have to continuously give it till about 20 weeks. And as we know that the evidence behind continuous use of progesterone till about 20 weeks, well, it's not very strong if routinely used. Unless, of course, the patient has recurrent miscarriages, then yes, of course, there is a reason to give it for a longer duration of time. So so that's basically, I would say, the misconception. And the other misconception would be a lot of people feel that that when a woman miscarriages, it most likely be due to a luteal phase defect or lack of progesterone. So it's not necessarily true.
I appreciate your insights, Doctor. It is essential to be aware of the challenges and misconceptions to ensure that doctors are providing the best possible care. And the final question for today is, what areas of research or clinical practice related to progesterone and luteal phase support in IVF do you think require further investigation?
Well, the first thing would be the amount of progesterone which is required for a woman. That was something which, and monitoring of the progesterone, which will indicate that there's a higher chance of pregnancy. An example, there are some studies that have shown that on the day of embryo transfer, if the progesterone levels are 8.8 nanogram and above, then the pregnancy chances are higher. Well, I feel that this kind of studies should be looked into more. There should be more according to a different ethnic or geographical area where more population should be in this kind of study, where we can know that which patient will have a higher chance of pregnancy. Hence, there's something we can do about it at the next cycle or at that immediate time. For example, if the levels are low, then we can increase the dose of progesterones before the embryo transfer. So I feel that's one research where we should look into the optimal amount of progesterone before an embryo transfer. The second thing is about the window of implantation. There are a lot of studies, there are a lot of tools that we have nowadays. For example, the ERA, where the endometrium receptivity analysis, or even the MIRA, the micro RNA test to check for window implantation. I feel that those are quite invasive. Hence, I look forward to using the newer products which are more blood-based, which you can use to determine the window of implantation for that particular woman. So which are not as invasive as the ERA or MIRA testing, where we have to scrape the womb lining. So non-invasive testing for window implantation be something which I think we should look into. The other part of research also would be the different comparison between different types of progesterone, and to check the levels of which one has the higher level in the circulation, and also eventually which one has the higher pregnancy rates. This is something which I think will be more beneficial to the population at large and to clinicians too. Yeah, so these are the few things which I would think that would be beneficial to with regards to the progesterones and the window implantation.
Dr. Navdeep, I just want to say a big thank you for joining us today and sharing your amazing insights and expertise. We're grateful for the time and effort you have put into educating us on this fascinating topic. Your knowledge and willingness to share it with us is truly appreciated.
Thank you very much again for inviting me to this night to give my insights about progesterone in IVF.
Before we wrap up, I would like to remind all of you about our MedSynapse platform, where you, as a healthcare professional, can actively participate in discussions and connect with experts. If you're looking for a community where you can engage in meaningful conversations about medicine and contribute to the advancement of healthcare, I highly recommend checking out MedSynapse. That's all for today. Until next time, take care and thank you for listening. Goodbye.